Hi guys, this is Amrit and I'd like to welcome you to OsProEd. This video is for educational purposes only and please never practice medical skills without the proper credentials. Okay, I'm super excited about this video and I would like to ask you, did you know about the assessment of bleeding risk prior to like a surgery or invasive procedure, or say like in a medical patient for whom we are starting anticoagulation? There are a few cases around this topic, so today we'll try to understand the topic and know a little bit about its key points, and hopefully, it'll all make sense. Okay, so when it comes to surgical patients, prior to the surgery, we ask a bleeding history. So we use like a structured patient interview or a questionnaire before surgery or before any invasive procedure. The goal is to assess bleeding risk. In this, the key questions that we need to ask include details of their personal and family bleeding history. We try and assess if they have any previous excessive post-traumatic or post-surgical bleeding, any use of antithrombotic drugs, if they have a history of comorbidities which may increase bleeding risk like bone marrow or renal or liver disease. Ask a detailed medical history, ask about the use of medications which might affect bleeding, for example, antiplatelets or anticoagulants or any complementary medications. Physical examination is another step. So we're looking for signs of bleeding, for example, petechia, purpura, hematomas, any signs of increased risk of bleeding, for example, jaundice, splenomegaly, arthropathy, joint and skin laxity. This information should be taken in all patients preoperatively and prior to invasive procedures. If the initial screen and bleeding history is negative, then no further coagulation testing is indicated. If the bleeding history is positive, or if there's a clear clinical indication of high-risk comorbidities like, say, liver disease, then a comprehensive assessment guided by clinical features is required. And a care plan will be under specialist guidelines or even hematology advice. If you have a patient with congenital bleeding disorders, preoperative assessment and surgery in patients with like a known or suspected von Willebrand disease or platelet defects or hemophilia A or B, and like other rare bleeding disorders should be, whenever possible, be undertaken in a hospital with like in close consultation with hematology. If bleeding disorders are positive on history and preoperative testing assessment needs to be done, then we think about like blood tests, for example, APTT, PT, INR, fibrinogen, and platelet count. Keep in mind that these are warranted in patients with bleeding disorders. When it comes to the assessment of bleeding risk, we need to understand that anticoagulation therapy increases the risk of bleeding. In general, before starting anticoagulant therapy, we assess the risk of bleeding in all patients. And we try to gauge the risk of bleeding, and to do that, there are a few factors we can look into, such as the degree of anticoagulation patient has been on, the duration of exposure to anticoagulation, and any pre-existing patient risk factors. So there are a few patient-associated risk factors that increase bleeding risk. So when taking an anticoagulant therapy, there are like a few factors like age. So for example, older than 65 years, prior bleeding episode, cancers, including like metastatic cancers, kidney failure, liver failure, thrombocytopenia, any history of prior stroke, diabetes, anemia, or having like a concurrent antiplatelet therapy or NSAID therapy, comorbidities that can result in reduced functional capacity, recent surgery or frequent falls or excessive alcohol intake. In Australia, we love using scores, and when it comes to bleeding risk, I can talk about a good example that we use in our everyday work life, and this is the HAS-BLED score, HAS-BLED score. This score estimates risk of major bleeding for patients on anticoagulation, like to help assess risk-benefit in atrial fibrillation care. Clinical risk scores can help with the initial discussion on whether to prescribe an anticoagulant for a patient or not. So, for example, like in atrial fibrillation, the main treatment in atrial fibrillation is usually rate and or rhythm control and anticoagulation. And to give someone anticoagulation, we use the help of HAS-BLED score, as this helps us for the bleeding risk assessment. So the HAS-BLED mnemonic has 7 parameters, and the mnemonic stands for H for hypertension, A for abnormal renal and liver function, S for stroke, B for bleeding, L for label INR, E for elderly, D for drugs or alcohol. So a calculated HAS-BLED score is between 0 to 9, and based on the 7 parameters, a score more than equal to 3 equals to like a high risk of bleeding, or for which like caution and regular review is recommended. If a patient has a high score, we can say that, you know, they're high risk of bleeding, as well as potentially modifiable bleeding risk factors. A high score does not necessarily indicate that anticoagulation medications should be avoided. Okay, so question, what can we do if there is a high bleeding risk present? So the short answer is treat the modifiable bleeding risk factors. So in patients with high bleeding risk, all bleeding risk factors should be identified, and modifiable risk factors should be addressed. So we try to understand like the patient based on the risk factors and include that in the HAS-BLED score. Apart from HAS-BLED score, there are like other bleeding risk assessments. There's one called Atria or Orbit or ABC, or there's another one called Hemorrhages. And the modifiable bleeding risk factors include things like hypertension, so say like systolic of more than 160, or a label INR, or medications that may predispose to bleeding, such as like antiplatelets or NSAIDs. Or like a patient with excessive alcohol consumption. So this is somebody with like say more than 8 drinks a week. And other like bleeding risk factors include like anemia, impaired kidney function, or reduced platelet count. And then, you know, you have your non-modifiable risk factors, which you can't do anything about. And these are, number 1, age. You can't do anything about age. Number 2, things like, say, history or major bleeding events, or previous stroke, or somebody who is dialysis dependent with kidney disease, or somebody with like cirrhotic liver disease or genetic factors. In summary, stroke and bleeding risk should be assessed on a patient-by-patient basis when considering an oral anticoagulant. But assessment of bleeding and other risks should continue throughout the treatment. All patients should be educated about the benefits and the risks associated with anticoagulant medication, so that, you know, they can contribute to the management decisions as well. So for example, some patients may accept a higher risk of bleeding knowing that they're avoiding a stroke. It's all about open communication in Australia, and we, you know, take the patient on the journey. Whenever prescribing anticoagulation, education and counseling for a patient prescribed an anticoagulant is very important. There is a case on counseling someone for anticoagulation. So examples of oral anticoagulations are warfarin, apixaban, rivaroxaban, etc. The education for a patient taking oral anticoagulant therapy could include information about like indication, like what is the drug used for, dosing, when to take the dose, what's the importance of not missing the dose, what actions to take if a dose is missed or duplicated, what are the side effects, what are the common adverse effects, when and what symptoms need to be reported to the GP. the duration, so expected duration of therapy, including planned timing of changes in the therapy. So maybe like also speak about monitoring, like timing of monitoring and the reason for blood testing, like for example, checking INR or checking kidney function. Bleeding risk as it applies to individual patients, like the risk of falling or if a prior bleeding episode has happened, signs of bleeding to look out for, so actions to take if bleeding occurs or these signs happen, what they can do. Education on sharing the news, so make other professionals aware of anticoagulant therapy, and consider like interactions as well, so with over-the-counter medications or alternative medications. Then speak about dietary like medication and relation to food, or the foods that should be avoided. It's all about structure, guys. So practice your cases based on structure. In the exam setting, if you get a case on bleeding risk assessment, don't forget to demonstrate your knowledge on the has bled score. You don't have to calculate it, but you simply need to ask the examiner or tell the examiner that I would like to know the has bled score, please. Okay. Other than this, when it comes to counseling, please have structure and you will ace it. If this was useful, then please don't forget to hit the like button and share it with your friends. Thank you.